With that, I'll move to ROS1. So similar to the lorlatinib data that we just looked at, with some of the data that we've seen for repotrectinib, which is a next generation ROS1 TKI, to me, this would now be the standard for the large majority of patients. Here we do see some activity against TRK as well, and so this drug is available both for NTRK and ROS1. It was designed to decrease the potential of developing ROS1 resistance. Here we're going to look at two cohorts of lung cancer patients who are TKI naive. These patients could have had prior chemotherapy, so they didn't have to necessarily be truly treatment naive. But you'll see that the response rate here was 79%, which is very impressive. For patients who had had a prior ROS1 TKI, and here that included crizotinib, entrectinib, and ceritinib, the response rate was 38%, with the majority of patients having some shrinkage of their tumor, even if it didn't meet our criteria of 30% shrinkage. For patients who were TKI naive, there was a median progression-free survival of 36 months, or essentially 3 years, without any evidence of progression of the cancer, new spots, or growth of what was there. For patients who had previously been on a ROS1 TKI, that time was 9 months. And so one of the big lessons here, and that I think we've heard throughout the day, is we do want to use our best drug first, because these numbers, which translate into very significant life responses to these medicines, are the highest when the best drug is given first. This drug works really well in the brain. So patients who had brain metastasis had even though these numbers are small, these are only 8 patients who had brain metastasis. The large majority of them did see a shrinkage in those brain metastasis on this drug. And that was true even if they'd had a prior ROS1 TKI. The toxicity of this drug is quite real. And so about half of patients did require a drug interruption, meaning a brief hold of the drug due to some amount of toxicity. And about a third of patients needed a dose reduction of the drug because of toxicity. We're still waiting to see what is the efficacy of this drug if a patient does require a dose reduction. Dizziness is one of the more unique toxicities that we see with this drug. 62% of patients reported some dizziness. 13% required a pharmacologic intervention, such as meclizine, and 3% had grade 3 dizziness. And just as a reminder, grade 2 dizziness can really significantly affect patients' lives. Grade 2 dizziness can give moderate unsteadiness or a sensation of movement, and can even limit instrumental ADLs, or activities of daily living. For me, what that really translates to is independence, and that's something that consistently is expressed as one of the most important things to patients, is the ability to remain independent. And so with sequencing of these TKIs, this is where, again, we can visually see the argument that starting with an earlier TKI, then using repotrectinib, the total duration on treatment is still going to be less than what we see with repotrectinib. Taletrectinib is an additional TKI that's coming, that's quite promising. Response rate of almost 90% for patients who hadn't been on a prior TKI. Progression-free survival or time on drug, almost 4 years here. And importantly, the tolerability here looks quite good. So patients can experience elevated LFTs, diarrhea, nausea, vomiting. But in general, this drug appears to be quite well tolerated by patients. So I think where taletrectinib will play in the ROS1 field, I look forward to seeing its use. Similar to the other nuvalent drug that we saw, NVL-520 is showing very good responses even for patients who've had prior repotrectinib. even if they've had multiple prior TKIs. An excellent toxicity profile from what we see in the early clinical trials, some LFT elevation, some weight increase.